Hello and welcome to this training episode that we'll be talking today about our bleeding and shock kits that were recently purchased for the fire department. My name is Dr. Eric Ernest. I'm the Assistant Medical Director for Omaha Fire.
I'm Sean Whittington, firefighter with the OFD paramedic, hired in 2000.
So today our focus will be talking about the new kits that were recently deployed. You'll find those on 16 of our current medic units, also 7 of the battalion chief vehicles, and it is also on the paramedic shift supervisor vehicle. And so there's some equipment that we should be pretty familiar with, but that we wanted to gather in kind of a consolidated area to make sure that should a mass casualty situation occur, that those are readily accessible and deployable. And so we'll be going through those kits, what the contents of those kits are in this training session, how to use the individual equipment, which should hopefully be reviewed for most of us, and just to get you a little bit more familiar. These kits are currently deployed and are out on the streets right now, so we want to just make sure that you've had a chance to familiarize yourself, and we'll go from there.
The kit contents include the following: an equipment bag, 12 combat application tourniquets with no expiration date, 12 emergency trauma dressings with a 5-year expiration date, 12 occlusive dressings with a 5-year expiration date, 12 Israeli pressure dressings with a 7-year expiration date, 12 decompression needles with a 5-year expiration date, 12 gauze rolls, 2 trauma shears, and 4 Coban rolls.
This is the CAT tourniquet that is stocked in all of the kits currently. It's also stocked in all the med units. When you deploy it, it's going to have to come out of the package. Indications for the tourniquet knot.
So any type of life-threatening bleeding, obviously we want to try direct pressure, but really when you look at some of the literature, when TCCC and some of the trauma literature, PHTLS, really if you have a concern for a pretty significant bleed, the idea is to try to stop the bleed as quickly as possible. So moving to a tourniquet quickly and rapidly for what you would presume is life-threatening hemorrhage, that's okay, and that's kind of where we want the mindset. As opposed to sitting there trying to apply direct pressure for 5-10 minutes and it's still kind of oozing and whatnot. If there's any question, moving to the tourniquet is okay and it's a safe thing to do.
When it deploys, you're going to pull it apart, and depending on if we're in rescue task force operations where things are a little chaotic, it's acceptable to apply the tourniquet as high as you can get up on the limb over a person's clothing, making sure there's nothing underneath in pockets or things like that that would obstruct it. Any other situations, you want to completely expose the injury, apply some direct pressure if we can, and then apply the tourniquet 2 to 3 inches above the injury. To deploy the tourniquet, we can slide it up over a limb, or in this case we're going to unthread it from around the extremity, 2 to 3 inches above the wound, rethread through the slot. And remove as much slack as possible. Attempt to put the tips of 3 fingers under the tourniquet. If you cannot do that, enough of the slack's taken out, you can begin to tighten the windlass. And tighten the windlass until the bleeding stops. And then secure the time strap. And then reassess the limb for any external hemorrhage, reassess for bleeding, and then check the distal pulse. And then write the time with a magic marker.
So it's important to remember that when working with tourniquets and life-threatening hemorrhage, that there really are no contraindications other than applying it to someone that really didn't need it. Say it's a small, slow venous bleed where it's not really that life-threatening hemorrhage. Other than that, really not a lot of contraindications to the procedure. What we have to remember is that that these are safe to put on. There's a time in the thinking way back when that if you're tourniqueting with something that was maybe a narrower band or something that would kind of cut into the skin, that you could do some damage. These being a broad band application device, that they really are a safe thing to use. And you look at some of the literature, these are safe for multiple hours of use. And so really within an urban system where we're going to get them to the hospital within a relatively short amount of time, this is safe for application, and we're not going to be losing limbs unnecessarily just because of the tourniquet application. So very safe thing to use and great to control that life-threatening hemorrhage.
All right, this is the North American Rescue Emergency Trauma Dressing. It's a 4-inch combination bandage that is going to be stocked in all the kits also. This bandage is for moderate to minimal bleeding or anytime you need just to create simply a pressure bandage, and this is just a quick and easy way to do that. So to deploy this particular bandage, you'll notice that there are tear notches on all 4 corners of the packaging, and kind of maybe a little pro tip here, something that might make that easier to find, and maybe if it was a low light situation, is to take a little piece of medical tape and just put where those tear notches are, and just make it easier to find when you need to. So when you open this up, and this is what you're going to have inside. All right, basically you've got your dressing and your bandage all as one single unit here. So I don't know if I can borrow your arm here, Doc. So basically what I'm going to do is I'll place the pad over the injury, make my first wrap. And you'll notice that on this particular bandage it has Velcro sewn every so many inches, and what those are brakes. So if you accidentally let go of it, it's not going to completely unroll on you across the ground, so it helps you to control it. And then it also, as you're wrapping, it helps to grab the bandage and maintain some pressure. So I want to go a little bit above, and I want to go a little bit below. And by doing that, it's going to help to keep it from sliding up and down so much when this person starts to move. And when you get to the end, all these bandages basically secure exactly the same way. You have these clips with some very sharp teeth on it, so all I need to do is to lift up one length of this, clip it, and my bandage is on. All right, each kit is also stocked with a twin pack of vented hyphen chest seals. Chest seals are indicated for any penetrating trauma in the torso between the collarbones and the belly button, anywhere around the body. We want to apply an occlusive dressing to those types of injuries. So how these deploy, tear notches on either side. You're going to open this up, and then the chest seal comes out. When you open it, there's a 4x4 in here, and what this is for is you want to use this to clean the area around the injury to get it as dry and clean as possible so that the seal will adhere. Then you discard this, and you notice there's a red tab, and that's what you're going to use to peel the backer off of the seal here. Now you notice that it is a vented seal, so we want to center the injury inside the vent here. Once we've done that, you want to take your fingers and press down and get as much air out of the edges of this as possible. Then now that once the seal's applied, then we want to continue to monitor the patient for any signs and symptoms of attention pneumothorax. All right, now we're going to talk about the Israeli bandages. This particular bandage is stocked in all of the ballistic vest kits that are on all the med units. So the initial teams that are going to be part of Rescue Task Force, this will be the bandage that's going to be part of the kit, and you're going to need to know how to use it. So this on this particular package, you see that there's only tear notches on one particular side of the bandage here. And again, I would recommend maybe putting a piece of medical tape close to that so it makes it easier to find under stress. Just open this package, and inside you're going to see that there's actually a second package that this is also wrapped into. Tear notch for this one, open this one up. And then this is the bandage that we have. Now you notice on the Israeli bandage, it has this pressure bar. And I'm going to show you how that works. Dustin, so basically what I'm going to do is I'm going to place the pad over the injury and with the pressure bar slightly off to the side. I'm going to make my first wrap. And then I'm going to go through the pressure bar. And then I'm going to reverse direction. What that does is it folds the pressure bar directly over the injury and adds a little more pinpoint pressure to it. Then I want to come a little high. Then I'm going to come a little bit low. Then I'm going to come back through the middle. Now something else you can also do, and this works also for the North American bandage, is if I put a twist in it over the injury, that helps to add a little more pinpoint pressure to it. And you'll also, with the Israeli bandage, there's a string in here that helps to act similarly to the Velcro on the North American bandage to keep it from falling off on you, or unrolling. Then when you get to the end, it has the same exact clips as the North American Rescue bandage, and you're simply going to find a spot to attach it, and you're good to go. All right, we're going to show you a couple of other things, a couple of different ways to use the Israeli bandage. These techniques also work with the North American Rescue bandage that you'll find in your kit also. So let's say we have a neck wound, and so the proper way to use the bandage for this is, maybe we can start out maybe just having the patient applying direct pressure themselves while I'm getting my equipment ready. Deploy my bandage, and apply it to one side of the neck. Now what I'm going to do instead, obviously we don't want to go all the way around the neck, circumferentially, we're going to go, I'm going to have the patient lift up his left arm, and I'm going to come under here. Since this is an Israeli bandage, I'm going to go through my pressure bar, reverse direction. When I get to the end, I'll secure it on the clip. Then you can have the patient drop their left arm, and that'll help to tighten that up. And another application that we can use for the Israeli bandage, potentially maybe if we have a head injury, this technique also works with the North American Rescue bandage. So I'm going to deploy my bandage, take the pad, I'll place it on the side of the injury, and I'm going to turn you to your other direction, Dustin. There you go. That's good. I'm going to come around the head and try to avoid getting into the patient's eyes. Go through the pressure bar, reverse direction. And then what I'm going to do is I'm going to actually use the pressure bar to help with my change of direction. I'm going to come over the top, and then up, and then I'm going to come around the chin. And what this is going to do is it's going to help to keep the bandage from sliding up the casualty's head. I want to keep it on the chin. I want to avoid his throat here. And when I get to the end, I'll simply take one of the clips, secure it. There you go.
All right, so the next procedure we're going to be talking about is needle decompression in the chest. And so when we're thinking about needle decompressing the chest, really what we're looking for are physiological signs of tension physiology. So commonly in a mass casualty type event, usually this will be some kind of penetrating trauma, be a gunshot wound, I guess stabbing would also fall into that. Or if you have a large blast injury where, say, someone's taking that blast force to their chest, they can end up rupturing their lung and develop pneumothorax that way. But more commonly what we'll see is probably penetrating trauma with gunshot wounds to the thorax, the chest area. So really when we think about tension physiology, we want to think about kind of three different factors. So difficulty breathing, they're going to be having difficulty in time respiring. Then also they're probably going to be tachycardic and then also hypotensive. Then you also notice probably diminished breath sounds if you have a chance to listen to their chest. So if you have a combination of that hypotension, tachycardia, diminished breath sounds, you really have to start worrying about either blood and or air filling up in that side of the hemithorax and starting to put pressure on the great structures of things like the heart and the vessels of the mediastinum. So if we have someone that we're concerned about that, the procedure that we have, so you'll take a large gauge needle. The ones that we have in the bleeding and shock kits is made by the air release system. These are a 10 gauge needle that's 3¼ inches long. We always want to remember that when going into the chest, especially someone with a thicker chest wall, that your standard angiocatheter IV is probably not going to be long enough to get through that chest wall and adequately decompress them. So really, we on the frontline med units, you guys will notice that there's a 12 gauge needle that's approximately 3 inches long. That will work as well, but the ones that are in the kit are the ones with this red cap here, come as kind of a self-contained system here. So when we're thinking about doing this procedure, we want to obviously identify which side we think the hemo or pneumothorax is on, and then want to identify our pertinent anatomy. Sometimes this can be a little bit difficult, especially if you have a more thick-walled or thick chest-walled person. And so some tips and tricks, we basically want to get in between the second and third rib in the mid-clavicular line. And really what I teach people, and for those who have done the cadaver labs and whatnot, you have to think about that there's about a baseball-sized area on the anterior chest, kind of above the nipple, below the clavicle, that really this is kind of a bit of a no man's land. That if you're anywhere kind of in this general vicinity, especially if you're having troubles with identifying anatomical landmarks, if this person has a completely collapsed lung from a pneumo or hemothorax, the lung tissue is going to be moved well out of the way. You're not going to be hitting any vital structures when you're going into that area. So really when we're thinking about this, most people you can find their sternal notch, even for a heavier set person. You can ride your fingers up onto the breastbone and feel that prominence or maneuvering of the sternum, and then you can walk it. That should be hopefully the third rib, and as you walk yourself over, you'll find the third rib. You can kind of go over the top between the second and third. And so when you're pulling this out, you'll uncap the needle. You'll get your needle with the subsequent catheter attached to it. And what I like to teach people is, as opposed to when you do a IV start, most people think of this as the bevel up, right? So that, you know, when you're going into that vein, you're going bevel up. I like to go bevel down when needle decompressing. The reason for that is that when you're putting the needle in, the idea is that we're going over the top of the rib, right? Because underneath lies the neurovascular bundle. We don't want to be hitting any vessels underneath. So if you imagine my finger being the rib and this needle coming in, if you have the bevel up, the needle tip has a tendency to kind of grab the rib and it's hard to slide up and over. If you go bevel down with this and you go on top of that rib, it more easily slides up and over the top of the rib, making it easier for insertion. So when we find that spot, we'll find that sternum, we'll walk over, find the second and third, between the second and third rib, second intercostal space, go ahead and we'll puncture the chest, and we'll go down. I'll go until I hit a rib and then kind of walk the needle over and then push it down in. And there's a couple different teachings on this. Once you make entry, go ahead and start pulling the needle out. Some of the newer literature, especially with the TCCC training program, is that you leave this catheter on the needle itself until the needle is all the way into the chest. That way we know that that catheter is not kinking or bending as you're going through the chest wall. Once you kind of hub that catheter, you can then at that point go ahead and pull your needle out. Should hopefully get either a rush of air or blood coming out of that and hopefully relieving the tension physiology. So once you have it in place, you can cap this. If you have a three-way stopcock available, usually in a mass casualty situation, we're probably not going to have that. You can also use the tip of a glove, anything to really prevent kind of air going back in there. But really the idea is to get this relieved. So even if you don't do that right away, the most important part is decompressing the chest. So if you have to put a second one in, say this one gets clogged or filled with blood products or other things, you can insert a second one near that area. And then obviously if you have to do it bilateral, that's acceptable as well. So.
All right, so we're going to discuss packing injuries. Packing wounds is going to be primarily our go-to treatment for junctional injuries. Areas of the body where we're too high, we're above the limb where we can't use a tourniquet, but we're not inside the abdomen, and then in kind of the shoulder neck area where we're not in where we can't apply a tourniquet, but we're not in the chest cavity. So kind of some basics for packing wounds. Obviously, we'd be having our BSI. First thing I need to do is I need to locate the source of the bleed. Depending on the type of injury it is, that may or may not be possible for me. So I apply direct pressure. If that's not being effective, I need to attempt to locate the source of the bleed. So what I'm going to do is I'm going to take some gauze and I'm going to try to remove any pooled blood and attempt to locate the exact source of the bleed. And as soon as I can do that, I'm going to take my gloved finger and I'll put it right on that source and start to control bleeding right away. I'm going to gather my gauze. The first thing I want to do is I want to gather enough material for my initial pack. I'm basically going to kind of wad up a ball. The Special Forces medics I've worked with call this, they call it a power ball. What I'm going to do is I'm going to take that ball and I'm going to stick it right where my finger is and again get direct pressure right back onto there. I'm going to gather more material, lift the finger, get the gauze back into the wound, apply pressure again. And I'm going to continue doing this until I've completely filled the cavity and applying pressure at all times against the injury. And the keys of this is being accurate is more important than trying to be quick with this. Once I have the cavity completely filled and packed all the way to the bone, any excess gauze I can simply place on top, and then I'm going to apply firm direct pressure. I have to give the body a chance to actually form a clot. So if I'm using standard gauze, I'm going to apply direct pressure for 10 minutes. After 10 minutes, I can access one of my pressure bandages. This is the North American Rescue bandage. And then I'll wrap this very tightly. And when we get to the end, we'll use our clips.
Well, thank you for taking the time to participate in this training. I want to remind everyone that these procedures, short of the needle decompression, are really meant for all levels of providers. These kits are both with the fire department and law enforcement. And really it's kind of a team effort, especially in a mass casualty type scenario where really these are not difficult skills. All levels of providers should be able to apply these, especially with tourniquets and whatnot for life-saving hemorrhage control, and to be able to get the patients out to a casualty collection point. So making sure that you're familiar with the kits, what's in those kits, how to use and apply the materials, so that way you're prepared for the next time we have a mass casualty in this area.